And our next speakers are Nama Julka-Anderson, Allied Health Professional Clinical Advisor for Macmillan Cancer Support, and Joe McNamara, Senior Lecturer and Co-Founder of RadChat, addressing healthcare inequalities for patients with having radiotherapy.
Thank you very much. Just to say, Joe's going to help with the World Cafe later, so I'm going to steal this bit. Sorry, Joe. But thanks for the invite for speaking today. So my name's Naman. I work as a research radiographer at the Royal Marsden, 3 days a week, and then I work for Macmillan, clearly with the branding, Wednesday and Friday as a national clinical advisor, and I'm also the co-founder of RadChat with Joe's other half of the face on it. When we think about equality, this is what equality stands for in the NHS, I would say, or in healthcare. Everyone wants to ride a bike, but everyone has different characteristics, but we don't really account for that very well in certain aspects. So we still try and force people to get on the bike regardless of what's going on with them. If you look at it in a different way, the tree could be the healthcare service or social care or anything like that. It's leaning towards one side, but both the people have a ladder to be able to reach, but obviously the person on the right can't get everything they need to. When it comes to consent forms, so specifically in radiotherapy, these are the Royal College of Radiologists national consent forms, which are used for patients and things like that. So we use these quite often. They're very, very detailed, lots of information about side effects, and I'm sure in any of your practice you'll use different consent forms as well. When it comes to toxicity tools, we use two specific ones called Radiation Therapy Oncology Group and Common Terminology Criteria for Adverse Events, CTCAE. Similar to any aspect of healthcare, we use these toxicity tools to make things easier for us. They were designed for clinical trials, things like that, and I'll come on to why this is important in a minute. So I'm here obviously to talk about skin, equity within skin. If you look around the room, everyone has a different amount of melanin. The more sun there is outside, there's more melanin being produced in your body. This is a cruder version of something called the Fitzpatrick scale, which was designed in the 1980s as an observation-based tool. So it's obviously a pictorial version of it. So number 1 to 4 is what was originally created for white skin, and then number 5 and 6 was added on for brown or black skin towards the end. But probably a year after this was published, the actual scale, there's been studies to say that for people of colour, the tool isn't as accessible or as good to characterise any skin problems for people of colour, because they were added on at the end without any research done towards it. So I'm supposed to be a number 4. There's lots of misconceptions that people with brown or black skin don't burn in the sun, but if I don't wear sun cream, I do burn quite often. So I've got a case study. Sorry, I should have said I've got some images of radiotherapy skin reactions. This is a case study that I use quite often, but it was one of my favourite patients who had black skin tone, Jamaican heritage, had a left tonsil, head and neck cancer, but was dismissed for a skin reaction because of how her skin was looking. So because of the pigmentation and the tools that I showed you earlier, everyone was looking for redness. So this tool on the right-hand side is a tool that I was trained on. So it uses that Radiation Therapy Oncology Group, the RTOG scoring. It says erythema, which means redness. And obviously it shows on the right-hand side the depth within the skin, which is also a white skin tone cut out of like cross-section of skin. But this is why my patient was missed. So despite having raised the issues about her skin, her saying that it was on fire, it was really painful. My colleague sent her home, and then she came out the next day with confluent moist exclamation similar to the image on the bottom, but obviously on her skin tone, and then was in an inpatient for about a week or so with sepsis. And every time I've gone back to this, and I always put this quote in, the answers that I've always got is textbooks only show white skin, which is why the patient was sent home. Obviously, I'm here to say that's not acceptable, and I'll go into some of the things that are being done to make that better, but just trying to build the picture that if the tools that the very tools that we're trained on only show white skin, we're going to struggle to be helping people of colour moving forward. So I know there's a lot of healthcare professionals here. I'm sure you know what skin is, and I know it's a white skin tone cutout, but it's quite hard to find a black skin tone cutout of skin. The epidermis helps with thermoregulation, it's a skin protection barrier, and then underneath the dermis is where you have the sweat glands, the hair follicles, so the important bits. And we don't normally damage the hypodermis through radiotherapy. But if you go out in the sun, so any time of the year, 24/7, we should be wearing SPF, so sun protection factor in the skin, through sun cream. What happens every time we step out is there'll be more melanin produced. So as I said, people's melanin goes up and down throughout the year. So the hand-like structure is the process of melanogenesis. So when sun from radiation from the sun, so UV rays hit the surface, or from radiotherapy, hits the surface. This process of melanin is what's produced, so that's what the erythema is underneath. So the melanin will look different on different people, but it'll be pushed up to the surface into the epidermis layer, protecting the nucleus. This will continue to happen, and this is how people end up tanning in the sun. But this is the same process for radiotherapy. So when we look back at the consent forms, my patient was consented on the head and neck consent form, and it said redness on it. So when I went through it with her afterwards, saying, well, what did your consent form say, as we always say about informed consent, well, she pointed out that it says redness, so I never even knew what to look for in my own skin. It's just something to consider, that even in your areas, this might still be the case around what is accepted on paper for people of colour. I spoke yesterday about this at a wounds care conference to 200 nurses and stuff, and quite a few people said they'd never even considered the difference, which is quite scary to think. At a wound conference, most of the pathways say redness. So for lymphedema, for example, for your legs, there's a look for red pathway, but for people of colour, that's never going to work. So that's just something to point out, that actually we're still very far away from offering that equality that I built with the cycle earlier. I talked about erythema. It's really important to point out that erythema physiologically is an increase in blood flow, but it looks differently on different skin tones. Depending on your local area, I know sometimes for physio, within physio as well, there are some tools that still say look for redness. But these two tools that we use regularly across the UK and the world haven't been changed since the 1990s. The British Association of Dermatology, so they highlight, obviously, as I said, that it's an increase of blood flow, but the misconceptions around skin tones, and actually redness itself as a term is misleading, because there's lots of colour spectrum changes. So for white skin tones, you may see pink or red, it says there, sometimes even purple, or it may become tan towards the end. And then for brown or black skin tones, there's different colour pigment changes. So actually, again, I know it's 2021, it's still quite recent, but the British Association of Dermatology are highlighting there isn't actually a straightforward way to predict erythema. So again, the tools that we're using, we're not really doing anything, we're not doing what we should be for people of colour. So this is what equity is, slightly different compared to equality. So 4 different people who want to be able to ride a bike, but we're altering the bike according to their needs. So that's how we should be viewing toxicity tools, consent forms. So looking at the tree, one of my favourite ways to point it out is, yes, we've given this person a taller ladder to be able to reach, but there's still only 2 apples for them to get to, because the system is still skewed over onto one side. So just something from a document, I think from 2022, Wounds Care International, and they've highlighted about assessing different skin tones. So I pointed out the 6 skin tones from the Fitzpatrick scale. This is a different version from 2015 by Ho and Robinson, who measured the inner arm of, I think, about 400 people-ish for different skin tones and the melanin content within them. So actually the number 1 is what they characterise as white skin, 2 to 5 is for brown skin tones, and 6 was for black skin tones. So very different to that Fitzpatrick scale. This actually has a lot more evidence and is being used across dermatology more to assess skin tones, and it's something that I'm trying to use as well. But just the key points around assessment. So it doesn't matter if you're not in radiotherapy, it's for any kind of skin condition. Is we shouldn't be looking for redness all the time. It doesn't work for everyone. Sometimes it might be maroon for people like me, or for people with black skin tones, it could be more subtly darker than the surrounding, different colour spectrum changes. But also it's okay to say that someone has brown skin or black skin. We don't need to be characterising them just from a tool. I think you can just ask your patient. Most patients are quite happy to know that you actually care about what their skin tone is. And I did get some laughs about this, but if your department can afford an infrared thermometer, please try and get one, because actually for black skin tones, it's not about the visual cues. It's also about the heat within the skin, or how it feels, the thickness-wise. And again, that's not just for radiotherapy, it could be for skin reactions as well. This is what I would like to see, is justice. So we fix the actual system that's there. I know it's being propped up by rope or wood, but it's better than what we're offering at the moment. I'd like just something to point you towards. I forgot to put the QR code on this slide, but if you do look it up, I published something recently. If you're looking for something to be able to reference the visual cues and the heat change cues within radiotherapy reactions, finally managed to publish something on it. And I think just to pause on here and say, we should also be confident in saying the problems with all these skin assessment tools, it is structural racism. It's something that hasn't changed for a long time. I've been talking about this for 2 years and I haven't really seen much else change. So I suppose the challenge to all of you is please take this away, try and do something else within your area about it. And if you don't agree, there's a World Cafe later where we can discuss it a bit further. I think I've talked really quickly, so thank you very much for letting me speak.
Yeah, that was brilliant. Thank you, Nathan. And thank you for the challenge. I think that's a great thing to take back to all our workplaces and look at these, particularly inequalities, which I think the more we're looking into it is the more inequalities we're finding. I think your discussion about the consent form highlights that you hadn't looked at a consent form and thinking that's the inequality in discussing erytherma. So I think that's really good. Thank you.